Hello everyone, good morning. Today we're going to talk about drugs for diabetes. This is an updated lecture. As you'll notice in many things that some things tend to evolve more rapidly than others. Diabetes happens to be one of those things. These slides were created by Dr. Mollenkopf and myself. So we're going to talk about drugs to treat diabetes, and she organized the content in terms of injectable and oral drugs, which I think is kind of brilliant. We already talked about the insulins, but there are other injectable drugs that are not insulins that we're going to talk about first. Then we're going to talk about the oral drugs. And we have a new member to the oral drugs that happens to be the SGLT2 inhibitor. One thing you do need to be aware of in looking at these drugs, there are gut hormones that are present called incretins that are secreted by the intestines that stimulate the release of insulin after eating. So we're going to be talking a little bit about incretins, so you might want to read up on some of those as well. So let's talk about the injectable drugs. Alright, the first injectable drug we're going to talk about are the incretin mimetics. Okay, and remember, incretins, GIP and GLP-1, and that's are both incretin hormones that are secreted by the intestine in response to having an elevated glucose. And these hormones then stimulate the pancreas to secrete insulin. Okay, so if glucose is present, then incretins help augment the secretion of insulin from the pancreas. So the first drug that's an incretin mimetic happens to be exenatide or Byetta. Okay, it activates GLP-1 and GIP receptors, causing the same stimulation of insulin release, and it's used in type 2 diabetes, usually adjunctive to other things like metformin. Adverse effects should make sense to you. So if you're stimulating insulin, you can potentially have hypoglycemia. These patients may also experience nausea and vomiting and diarrhea, which are common. Less common are pancreatitis, renal impairment, and allergy. Pancreatitis is something you definitely want to be aware of because remember, it's stimulating action in the pancreas. Drug-drug interactions, oral contraceptives and antibiotics. If you take this drug, it impacts the absorption of both of these drugs, so patients need to be aware of that. And if you take it, remember, this is an adjunctive drug, so if you take it with a sulfonylurea or something else, it can cause an increased risk of hypoglycemia. This is given via pen, and just like with any pen, we don't share them. It's really important for patients to know the signs and symptoms of hypoglycemia and pancreatitis. And you should be giving this drug about 60 minutes prior to the meal. And to properly store exenatide, it should be stored in a fridge. So here's a little chart about the incretin mimetics and DPP-4 inhibitors. You'll notice that incretins stimulate insulin release, and they also inhibit glucagon release, so it causes a lowering blood glucose two ways. DPP-4 happens to be a hormone that that causes the breakdown of these incretins. So if you have a DPP-4 inhibitor, it prevents the breakdown of the incretins, and then which allows for insulin release. So the next drug we're going to talk about are amylin mimetics, Just like the name says, it mimics amylin, which is a hormone that's co-secreted with insulin from the beta cells. It suppresses glucagon release by decreasing hepatic glucose production. So the main way that this works is it decreases gastric emptying. Okay, because it decreases gastric emptying and GI motility, it provides more of a sated response by the person. So you feel less hungry, you have less intake. It can be used adjunctive with type 1 diabetes, so those patients take insulin and they may also take this, and type 2 diabetes. Now the adverse effect is hypoglycemia, but as the book's going to tell you, pramlintide does not cause hypoglycemia when used alone. But since it's adjunct with other things, it can really enhance hypoglycemia when it's used with other things, which it always is. Other common concerns are nausea and vomiting and diarrhea. Drug-drug interactions will make sense. Drugs that also slow GI motility, like anticholinergics and opioids, this drug will further slow down GI motility. Plus, because gastric emptying is slowed, absorption of other oral drugs are inhibited. And this will make sense why, with nursing implications, you administer this other oral drugs either an hour before you give pramlintide or 2 hours after, so that the drugs are absorbed. This drug particularly comes in a pre-filled pen. You refrigerate unless it's in use. Then once you use it, it can be kept either refrigerated or at room temperature for 28 days. Patients need to know that they administer just prior to meals, and it takes about 20 minutes for this to start to work, and they should know the signs and symptoms of hypoglycemia. Okay, let's look at now the oral drugs. So you notice the two injectable drugs are incretin mimetics and amylin mimetics. The other drugs that we're going to talk about are all oral. So the next drug we're going to talk about are biguanides. The prototype's metformin. You might hear about it. It's glucophage. Method of action. So it decreases hepatic glucose production and increases glucose uptake by the muscles and fat. You'll notice it does not stimulate insulin release. Be sure to mark that. That's kind of important. And it's weight neutral. A lot of these drugs will cause patients to gain weight, which is very unpleasant. Therapeutic uses, so it's drug of choice for diabetes type 2 initial therapy. And that's what DOC stands for, drug of choice. The other thing it's used for is polycystic ovarian syndrome. This syndrome is characterized by androgen excess and insulin resistance, so it helps with insulin sensitivity, and it reduces androgen levels too, and actually improves ovulation in these patients. Pharmacokinetics, it's eliminated unchanged by the kidneys. And adverse effects. So the common ones, the GI ones, decreased appetite, nausea, vomiting, diarrhea, abdominal bloating, and flatulence are very common, and they will subside over time. However, it is kind of important that some people really can't tolerate them. So it's important that they start with low doses of this drug and titrate up as to minimize these adverse effects. The serious adverse effect, however, happens to be lactic acidosis. It's rare but life-threatening, so it can happen in 1 in 33,000 patients. And here's what happens. You have lactic acid buildup. Signs and symptoms can be exhaustion, fatigue, weakness, abdominal pain, diarrhea, decreased appetite and headache. and this can be life-threatening. So other drug-drug interactions, cimetidine actually increases the risk of lactic acidosis. So iodine contrast dyes, this can really wreak havoc on somebody's kidneys. So anything where the kidneys, the GFR decreases, can increase the serum levels of metformin, increasing someone's risk for lactic acidosis. And alcohol inhibits the breakdown of lactic acid as well, so it can increase someone's risk of lactic acidosis. Similarly, individual variation will make sense. So anyone with renal disease, we watch very closely, especially if they have a eGFR less than 30 mils per minute. It's contraindicated. We avoid in patients that are prone to lactic acidosis. So heart failure patients are prone to lactic acidosis. Those with renal dysfunction, obviously, because metformin is excreted. Liver dysfunction, you have a buildup of lactic acid or excessive alcohol ingestion. Other conditions that might also have an increased risk of lactic acidosis might be severe infections and patients that are already septic. So nursing implications with biguanides or metformin. Number one, we want decrease GI symptoms by giving this with food. Remember, we're going to start with a low dose and gradually titrate upward. Patients need to know the signs and symptoms of lactic acidosis and report this to their provider immediately. So the next group we're going to talk about are sulfonylureas. Glipizide is the prototype. Method of action is it stimulates the release of insulin from pancreatic beta cells. So you'll know that it can be only used in type 2 diabetes alone or with combinations of other drugs. So unlike metformin, it can cause weight gain, and it does stimulate insulin release. Adverse effects, the big ones, hypoglycemia. GI disturbances are fairly common, and the disturbances you'll see will be nausea, diarrhea, flatulence, and they can be dose related. You can have other things like itchiness, a rash. You can have some neurologic adverse effects, dizziness, nervousness, headache, and tremor that you can see with hypoglycemia as well. Big things are drug-drug interactions. Now, glipizide happens to be a second generation sulfonylurea. So really, sulfonylureas come in 3 generations. The second one works better, obviously. But one drug-drug interaction it has is alcohol. So with alcohol, if someone's drinking and they're on this drug, they can have what we call a disulfiram-like reaction. This patient will start to sweat, they'll have palpitations, maybe even tachycardia and nausea, and they will feel incredibly sick. Other interactions would make sense. So if you take it with another hypoglycemic drug, taking a sulfonylurea can further cause hypoglycemia. And beta blockers. Beta blockers have an interaction with sulfonylureas in that they diminish or suppress insulin release. Plus, patients that are also on beta blockers, they may not recognize hypoglycemia because with hypoglycemia you have tachycardia. Beta blockers will suppress that. So in looking at individual variation, we watch anyone very closely if they have renal or liver disease. Sulfonylureas are metabolized by the liver and excreted by the kidneys. So if you have renal dysfunction, you'll have increased levels of this drug and hence potential increase of hypoglycemia. fetal risk and risk to the baby cannot be ruled out in either pregnancy or lactation. As a nurse, it's really important to educate your patient on the signs and symptoms of hypoglycemia. They should know what drug-drug interactions can happen. They need to avoid alcohol, even some subtle things that have alcohol, like vanilla has alcohol in it. They should take it with food if GI upset occurs, and they really shouldn't take it if they're pregnant or lactating. The next group we're going to talk about happen to be the gliptinonides. Repaglinide or Prandin is the prototype, and its method of action is similar to the sulfonylureas. So it is ATP sensitive on the beta cells and causes insulin release. Really, you need to know that it causes insulin release, same as the sulfonylureas. So if the sulfonylureas don't work, this group of drugs won't work either. Unlike the sulfonylureas, the glinides actually are short-acting, and they're taken with each meal, so it's just a little bit different. So they stimulate insulin release, and they may cause weight gain. You can take this drug either type 2 diabetes alone or in combination with metformin. It peaks within an hour. Its main adverse effect happens to be hypoglycemia, and as a nurse giving this drug, you give it 30 minutes before each meal, and patients should know the signs and symptoms of hypoglycemia. The next group we're going to talk about are the TZDs. Pioglitazone is the prototype. The glitazones in general are a new drug. There's one that's off the market because of hepatic failure, and another one off the market because of MI death, but Actos is still on the market. It reduces insulin resistance and decreases glucose production. So it does not stimulate insulin release, and it can cause weight gain. Therapeutic uses, you can use it with type 2 diabetes alone or in combination with other drugs. It does have some serious adverse effects, but before I talk about them, the other thing that's important is it might require 4 to 12 weeks for maximum clinical effect. Now let's get back to the adverse effects. It has some very odd adverse effects. You can have upper respiratory infection, headache, sinusitis, myalgia, elevated LDL. The more worrisome ones, if that isn't worrisome enough, is you can have fluid retention secondary to renal retention of fluid. So heart failure can be an adverse effect, so you be very, very careful, or even contraindicated use in someone with heart failure. You can have hypoglycemia if it's also given with insulin, and it increases a patient's risk for bladder cancer. One other interesting effect is that those women that are postmenopausal, this drug can actually stimulate ovulation. So it's really important that anyone who may think that they can't get pregnant, if they're started on this drug, it is possible. As mentioned before, individual variation, those patients with heart failure really should avoid in serious heart failure. Other nursing implications, patients that have liver damage, we really monitor their liver enzymes baseline every 3 to 6 months afterwards. And patients should know that to look for signs and symptoms of heart failure. They should know that this drug increases their risk of bladder cancer, and as I mentioned, have to use contraception for those postmenopausal women. The alpha-glucosidase inhibitors are the next drug type. The prototypes happens to be acarbose. This method of action is that it slows carbohydrate absorption and digestion in the intestines. So this doesn't stimulate insulin release. This can be used for type 2 diabetes alone or in combination. Here it's written that it's rarely used in the United States. It's really good for postprandial hyperglycemia. The reason why a lot of patients don't like it is because it doesn't allow for absorption of food content. You can have flatulence, cramps, abdominal distension. It causes a lot of GI effects because you actually have bacterial fermentation of undigested carbohydrates in the GI tract, so it's uncomfortable. Big adverse effects here. The GI effects, it can also cause anemia and hepatotoxicity. As nurses, it's important that patients know you administer this drug with the first bite of the meal, and they must use glucose or fructose if the patient develops hypoglycemia, so they can't have complex sugars. The DPP-4 inhibitors are the next group. Sitagliptin is the prototype. Januvia is the trade name. I love this name because it sounds like a country, especially in Princess Diaries. Januvia. Anyway, this drug itself blocks the degradation of GLP-1. Remember, incretin hormone. So that hormone stimulates insulin release. Okay, so if we have an DPP-4 actually metabolizes that hormone. So the end result is that you have glucose-dependent insulin secretion because GLP-1 is available to augment insulin secretion. You don't really have weight gain with this. It's second-line agent for type 2 diabetes. It's well tolerated. You can have some other adverse effects like upper respiratory infection, headache, nasal inflammation, pancreatitis, which is rare, and hypersensitivity. And really, patients just need to know the signs and symptoms of pancreatitis. So here's a little picture of where DPP-4 actually comes into effect. So DPP-4 prevents DPP-4 inhibitor prevents DPP-4 from metabolizing GLP-1. Really, the end result is insulin secretion. So the next drug class is an SGLT2 inhibitor. So canagliflozin, or Invokana, its trade name, is the prototype. It inhibits SGLT2 in the kidney. So what happens here essentially is it promotes excretion of glucose in the urine. This is kind of useful, especially in type 2 diabetes, although it is being studied with patients with diabetes type 1. And with higher presence of glucose in the urine, the adverse effects are going to make complete sense. You're going to have an increased amount of infections, fungal infections, urinary tract infections, and increased urination. Serious adverse effects are all relate to this: urosepsis, pyelonephritis, increased risk of amputation, and you can have euglycemic diabetic ketoacidosis. It's acidosis where the glucose level is less than 300 and the bicarb level is less than 10. And it's associated with ketonemia and ketonuria. It's usually caused by starvation in conjunction with illness or in patients with diabetes. So that's a very unique syndrome there. Other weird things, you can have adverse effects. You can have postural hypertension, dizziness, when combined with diuretics in older adults. So other things, drug-drug interactions, inducers such as rifampin, phenytoin, phenobarb can decrease efficacy of Invokana. Other things, it has a half-life of 12 hours, so you can have once-a-day dosing. So patients should take it before the first meal of the day. We really need to monitor kidney function. For those that have a GFR of less than 30 mils per minute is contraindicated. We really start at a recommended dose at 100 milligrams a day, and they should have a GFR of 60 mils per minute. So when studying for this unit, it's really kind of important to consider, how these drug classes differ. For instance, the glitazones, pioglitazone is the prototype. For instance, you want to make sure that those patients, especially if they're postmenopausal, that they take birth control. You want to know which drugs are injectable, which ones are oral, which ones stimulate insulin release, which ones cause weight gain, which ones increase insulin sensitivity of the body. So after you review your drugs, then it's nice to be able to compare adverse effects as well. Okay, that's it. Good luck.